Thank you so much. Good morning, Coalition. And I'm so excited to have Dr. Kevin Biese here. We've been colleagues for a really long time, and we now get to catch up. And he has so many academic and clinical titles. Virginia and I weren't even sure which ones to use. So, chair of the Geriatric Emergency Department, Accreditation Board of Governors, co-director, Division of Geriatric Medicine, associate professor, emergency medicine, vice chair, academic affairs. There's a lot, Dr. Biese. Basically, I'm ready to just turn it over to you to talk about all things emergency medicine and geriatric emergency medicine. But first, I just want to say welcome.
Well, thank you, Heather and team. I'm really grateful to be a part of this group. I think this group makes a tremendous difference for the people of North Carolina. And so appreciate your generosity and having and existing and advocating and collaborating and finding those opportunities to improve care for the people of our state. And so really appreciate it. So my name is Kevin. I'm an ER doc. I'm an emergency medicine doc at Hart. I worked in the ER Wednesday and Monday and blah, blah, blah. And I get to spend most of my time working on care redesign for emergency departments for the care of older adults. And that takes lots of different forms. That takes, taking care of older adults in the emergency department. I'm the vice chair of our UNC Healthcare Alliance. I'm a physician and administrator type person at the University of North Carolina's healthcare system. And so our Health Alliance is the value-based care coalition that works across our 10 hospitals to contract with all the MA plans and CMS and others. I actually spend a lot of time on the phone with CMS. I met with them extensively for the last couple of months working on something called the Geriatrics Inpatient Hospital Measure, which could evolve the standards of care for older adults that are hospitalized across the country as early as this spring. I work with a group called West Health, which is a philanthropic group dedicated to improving care of older adults and really helping push forward geriatric emergency departments. I work with a group called John A. Hartford, which is similar, got a policy office in DC and blah, blah, blah. But basically, I know one thing, and one thing other than loving my wife and kids is how do we begin to try and make emergency care better for older adults? So when someone is having a bad day, and they need acute unscheduled care, which in this country is often, especially for older adults, administered in the emergency department, but doesn't have to be. That's another talk. Then how do we make that go better? And how do we begin to align some of the forces that are in our society and in our community, which are basically pretty simple? The fact is that we spend an inordinate amount of money on acute unscheduled care for older adults. And as a system, we do a crappy job of managing acute unscheduled care for older adults. And so there's a tremendous opportunity to do that better. And so let me share, if I can, I'll dive into just a couple of slides of what I mean by a geriatric emergency department and some of the progress that we've made on that front, and then open it up for conversation. So I'm just gonna.
Yeah, that's great. And it's so funny. I was joking around in the introduction. I was going to do that, like, Dr. Biese, you could just take it away and just talk and we'll just sit back. I have all kinds of questions. And then we had spoken that you had some slides to share and we'd love to see it. And if we have time, I also want to dive into you because you are fascinating. Every innovative or cool or thoughtful thing that I've been a part of for the past 15 years, I show up in the audience, and who's on the panel? You. I go in a conference room, and who walks in the door? There. I'm like, there's Kevin. I must be in the right place. If Dr. Biese is here, then this is where I need to be when it comes to geriatric emergency medicine. But if we have time, I did stalk you, my friend, and I saw that you went to college and you studied theology. And you have your master's in teaching. So I'm kind of curious about how you landed with a white coat, considering you were taking a different path. So I know you want to get into the slides, but we always like to take a moment to sort of say, who are we really talking to and what's your background?
Well, at first I was afraid you were going to get me arrested for stalking you based on that description. Like, where'd this guy come from again? Oh my God.
We've all been we've been friends for more than 15 years. Stalking is allowed, or we should say a classic. I researched you in preparation, but I was like, what's Kevin been doing online? Okay.
No, that's super kind of you. Yeah, I grew up in the Midwest and I went to Notre Dame. Kind of I like many decisions, it just kind of happened. In fact, the first football game was coming up for those of you who pay any attention to college football. I did not. And there was all these signs up and I looked at my friend Brian and I said, Brian, is football a big deal here? And I was already enrolled at the University of Notre Dame. So that tells you my situational awareness. It turns out it is a big deal to us. And then I taught 7th and 8th, and I majored in the program of liberal studies. So we just sat around and read books and talked about them and theology. And then I taught 7th and 8th grade for 2 years. Somewhere in the middle of college, I decided I needed a job. And I was like, I guess I'll go to med school. So I took enough science classes to qualify. I went and taught 7th and 8th grade for 2 years. They sent me to Charlotte, North Carolina. So Notre Dame copied Teach for America in Catholic schools. And basically you lived in community and it was a great experience. I loved it. For those of you who don't study Latin, doctor comes from the Latin word docere, meaning to teach. And so it's not a completely divergent pathway, I would argue. And so I got into the University of North Carolina, and at the time there were some scholarships and it was essentially free. And some of my older cousins that had gone into medicine, I'd gotten into some, even fancier named schools. And they were like, well, I'll beat you up if you go to the ones that you have to pay. You should go to the one that's free. And I was like, okay, I don't want to get beat up. So I came to the University of North Carolina for med school. And then went up to and was mentored by so many wonderful people here, including one Steve Kaiser, who was a geriatrician with us for a long time, and would try and get me to sit down long enough to learn something. So I appreciate that. Went up to Boston or Harvard for residency, and in residency came to realize that, I loved emergency medicine. I went into emergency medicine for helicopters and chest tubes and machines that go ping and drama and the show of the ER, and like it was awesome. And yet when I looked around, that wasn't most of what we do. And it didn't require a genius to figure out that we were missing the mark on caring for complicated older adults, that not because the nurses and doctors and others weren't great, we are, but like because the system was just malaligned. It was misdirected. It does not work. And so I experienced all of that when I came back to the University of North Carolina. Jan Busby Whitehead, who's been the chief of geriatrics here for a long time, adopted me, and said, I know you're interested in older adults. Let's do some stuff in the ER. And then it just grew. I was our residency director. So I trained all the emergency medicine physicians for a number of years. And in that process was able to create fellowships, so additional training for geriatric emergency medicine around the country, create a curriculum for residents in emergency medicine. And then over the last 10 years or so, it's gone more into policy and advocacy, working with, CMS, working on care delivery programs, and working on some of the programs I'll share here. But really, it's all stems out of that moment standing in the hallway, looking at a 82-year-old woman who was in the hallway of Mass General Hospital, and in our ER. And I had left that shift 12 hours before on the night. And I came in 12 hours later and she was still there, same woman, same cot, same hallway. And my grandmother helped raise me. And I was like, well, this is not okay. And so the whole journey that we'll talk about for me personally comes down from a moment of this is not okay. And how can we begin to align forces to do a better job?
Yes, well, I know I'm excited for you to share your slides. Thank you for sharing your journey. And I know that I hope your slides dive into it, because the other question, not that we need a reminder, but remind us again why we don't want to go to the emergency room, especially if we're older adults. So I'm hoping I know you have some slides. I hope your slides will go to the genesis of the woman in the cot that you saw for 12 hours, which, by the way, that, may have been me and my mom after 16 hours. And I think one time you did visit us in the hallway of UNC when I was like, I'm here with my mom and she's in the hallway. Thankfully, she was semi-conscious, but I was the one standing next to her in that hallway for 15 hours, and you know that. So tell us why in your presentation, if you want to start sharing the slides, why ERs just really aren't great for older adults, anyone in general, but especially our older loved ones.
Oh, absolutely. So let me I'm gonna take a few slides if I can from different talks that I've been fortunate to give around. So I apologize. You'll see me jump from different. I'm not going to bore you with the whole presentation. So you'll see me jump just a little bit. But just a couple words on what I even mean by a geriatric emergency department. And, Heather, I just want to respond to the point you made just a second ago. It's spot on. Going to the emergency department, especially if you're a frail individual, a frail older adult, or their caregiver or loved one, is an extraordinarily challenging process. My hope is that we can make it a little less undesirable to go there. No one wants to be there. And so I apologize. I will get to the slides, but I was talking once with Eric Harden, who is the Deputy Secretary of Health and Human Services with the last administration. So I was up in the HHS building, which is just next to the Capitol. We weren't storming it that day, so it was a good day in DC. And but you're looking over the Capitol, and Eric's sitting there, and I'm kind of like anxious, and we're meeting, and he's got 15 minutes on his calendar to meet about emergency medicine. And I'm giving him my geriatric ED speech, which you're hearing part of today. And he let me go on for like 5 minutes. And he looked at me and he said, "Kevin, don't you know that we don't want anyone to go to the emergency department? Why would you try and make geriatric emergency departments? We don't want them to go there." And since I already have tenure, I said, "That's great, sir. How's that working for you?" And he laughed, and we met for another half an hour. So I don't want to have to take my mom to the emergency department or my dad, and I don't want anyone here to have that experience. But I also want to make sure that for the 29 million plus age 65 and older ED visits there are a year in this country, and that number is only going up, that when that time comes, it can be a little better. There are forces that make it hard to make it be exactly what we want it to be, but it can be better. Avoidance only got us so far. We've put a lot of money and effort into better preventative care, better integration with PCPs, not nearly enough. But older individuals will still have bad days. And how do we respond to that the right way? So Ms. Smith, this is a journey, a typical emergency department journey, or typical acute unscheduled care journey for an older adult. And just to talk about it for a second, obviously fictional. Ms. Smith is 82 years old, has mild to moderate cognitive impairment, but lives alone, functions pretty well, has some food insecurity, has diabetes. She loves to garden. She falls, the shovel hits her foot. She calls her doctor's office because her foot hurts and it looks a little red. And her doctor's office is an answering machine. And the only thing she can understand from it is, call 911 if you've got a real problem, because it's impossible to navigate those machines. Well, she doesn't, because she's smart. And she's like, I don't want to do that. She goes to bed. She wakes up the next day. She's got a fever. She's diabetic. Her foot hurts. So she calls her doctor's office again. She understands to call 911. So she calls 911. The ambulance comes. Ambulances in this country, unless you're part of a specific CMMI program, only get paid to take you to the hospital. And so not that they necessarily could take her somewhere else, but the system is designed for the ambulance to take that person to the hospital. And so it's changing, and so off to the hospital they go, where she is doomed to be registered as what we call an emergency severity index 3, triaged as a level 3. What that means is she waits forever. So the way emergency department triage works is level 1 is you're dying, and level 5 is you stubbed your toe. And people that are complicated but don't look like they're dying end up being level 3s. And for a number of reasons, older adults will often end up as level 3s. Sometimes they have a difficult time telling their story quite as well. Sometimes their physiological responses, their heart rate and stuff don't show how sick they are, even though they're that sick. But they end up as level 3s. And level 3 means I can't get you out here quickly, and you're not the first one to come back. So paradoxically, disastrously, individuals that are most prone to suffer the adverse effects of long emergency department stays are most likely to get long emergency department stays. And this data plays out nationally. So after she's in the hallway, in the waiting room and in the hallway, and it's not medically complicated, we know to give her antibiotics, and it's easy to give antibiotics in the hospital. And so we admit her to the hospital. But by this time, this low-level underlying dementia has become delirium, which increases her hospital stay by about 3.5 days. So she's in the hospital for a prolonged period of time. She's really mislabeled. She goes to a rehab after about an 8-day stay, and these are based on national averages. And we've spent a tremendous amount of money. The money only matters because it's opportunity. If we can align these forces, we can transform care. But so we spent on average in this country on her total episode probably $17,000 to $21,000. And you know the problem? You don't see a picture of her gardening again in this. The fundamental miss here is that we've done all of this stuff and everyone on the conveyor belt has done the right next thing. She was hurt. She called her doctor. The doctor's office said to call 911. She did. The ambulance took good care of her and brought her to the hospital. They used the right scale in theory and triaged her. They got her the right medications. They responded to her increasing confusion with the medications that in theory you're supposed to use. I realize it, but like there's no one person on the conveyor belt did anything that was like clearly wrong. Like, how dare you do this? You didn't diagnose her. You didn't give her the medication. You didn't. They all did the right thing. The whole conveyor belt's just pointed in the wrong direction. It doesn't make sense. How can we as a society totally miss out on Miss Smith's goals of care and what matters to her, while simultaneously putting a tremendous amount of resources in our efforts to miss? I mean, it doesn't really make sense. So what's a geriatric ED? Same situation. What's that?
I was excited. I was like, all right, fix it. Where's it? Literally, since we're talking about gardening, where's the rose-colored situation here? Get us back to the roses and happiness.
Let's just say that we're trying to infuse a hue of rose. We need stronger psychedelics than I'm allowed to prescribe in order to feel completely jubilant about emergency or any other healthcare right now. But a geriatric emergency department is the hub of disruption. It's the center of a hub of disruption. So you can certainly and frequently do telehealth from it to try and treat people at home or send home health or advanced home health. I was just meeting with the directors of the hospital at home program that you may have heard of. So Bruce Leff and Al Sue got that passed through CMS and was just passed as part of Omnibus. So it's funded for at least 2 more years on a federal basis. And so there's all kinds of resources where you can use telehealth and get the care you need at home. But if you can't do that, and you have to come into the hospital, a geriatric emergency department is a place where the team has been trained up in the policies the protocols, the care processes, the education, the connections with the community in order to not swing and miss in the same way that happened before. So a geriatric ED is about educating people about geriatric syndromes, right? We know in emergency medicine that a 2-year-old is not just a smaller 40-year-old. Well, an 80-year-old isn't just a 40-year-old either. There's a lot of different things going on there. How do you make sure the team knows that? It's about having the care processes in place that identify these underlying problems. So it's about screening for falls, delirium, polypharmacy. It's about the interdisciplinary teams that allow that to happen. Including care managers, social workers, pharmacists, physical therapy, so that at the end of the day, you take what is a bad event and get people the care that they need. You use it as an unfortunate opportunity to address the underlying situations, so that we don't just treat the infected foot, which by the way, you can often do at home as per this diagram, both helping the patient get home if that's a good place for her to be. And again, it's not about the money, but you can save lots of money this way too, if you just connect the dots, which matters because then you can be sustainable, right? Medicare solvency matters. And so you can get people back home and you can identify what's going on beneath it. So wait, you're on 2 different beta blockers. One from your cardiologist and one from your primary care doctor. We need to redirect that. Wait a second, we can have the EMS team do a home health evaluation, a home safety evaluation while they're there, make sure that the fall hazards are relieved. We have physical therapy see you in the emergency department before you leave to make sure that you're safe to go home. And we also screen for underlying social vulnerabilities, such as the program we have at UNC where we connect you with Meals on Wheels. So as long as you're stuck coming to the ER, let's take advantage of this to not just fix you up from the fall you had, but to help you not fall again next week. Because in older adults, a lot of things that are isolated events in younger folks are part of an underlying syndrome or repetitive patterns in older adults. And how do we address those underlying conditions? So a geriatric ED gets you on a path to higher value care. Most importantly, usually the patient's values, which are not being stuck in the hospital or the hallway for days at a time, and instead getting the care they need. So I don't know if that helps at all, Heather, but I can share more in a second, but that's what a geriatric ED is.
It helps, and it also became sort of like, I know we only have a few minutes left. It became sort of like bingo, discussion bingo of all, besides what's happening in the geriatric emergency rooms. You threw in hospital to home, you threw in telehealth, you threw in policy change. So we've got a few things that I want to dive into, but Harold Barnett, one of our coalition members, asked a question that I think is really thoughtful here, because, and if you see it in the chat, some expect entire hospital systems are now, and they've become triage centers as the volume of healthcare demand explodes with the aging population. How may the lessons of emergency medicine scale to system level practices in the future?
Yeah, so I think that's already starting to happen in some ways. So for example, Mass General Brigham is in the process of building another 400-bed hospital, except it's not a hospital. It's a 400-bed hospital at home program. So what they're doing actually is putting those resources and deploying them outside the buildings of the hospital. And so I think that what we see happening nationally is that our government is trying to move us towards something value-based care or risk-based care contracting, which at least conceptually I'm a big fan of, and conceptually makes sense. The devil's always in the details. It's complicated. We don't really walk there, in my opinion. We're drunkenly stumbling towards value-based care. But as soon as you start to be accountable, not for how many things I do to you, but how can I do them driving the highest quality, aligning them with what matters to you, and in the most sustainable way, efficient way possible, we start to realize that building more hotels with painful amenities, which I think is kind of what hospitals are not the best way forward. And instead, how can we begin to wrap services around you at home when appropriate? Now, if you need your aorta repaired, we're not going to do that in your living room. Like, there are things that need to be done in the hospital. Absolutely. But as we incentivize, as we begin to work with, systems like UNC Healthcare and others around the country to incentivize, quote unquote, higher value care, we begin to see innovative models of care where people spend less time in the hotel with painful amenities, more time at home, which of course is, if you can do it, more sustainable, because you're not paying rent in two places. I mean, just to make it real simple. And in doing so, meet the patient's needs. So yeah, I think that's the direction we are going in. It's going to be a bumpy journey to get there.
Yeah, well, and I have a question about the bumpy journey, and I know that a question just came in from Karen Appert. How many geriatric EDs are there in North Carolina? And I might add, and nationally, like, how is this taking off in North Carolina? Is this taking off? Because I know you're hanging out with lots of folks in DC and other parts of the country. So, we've got a slide.
So actually, this is a little
good segue,
old.
Karen.
It's a little old. There's actually over like 410 geriatric EDs right now. To be honest, I'd have to look at how many there are in North Carolina. My guess is 7 to 10. I can look that up, and I can do that in just a second. And I'll chat in a second where you can go, the website you can go to find out the names of the geriatric EDs, because you might want to know which ones around you. In the triangle, it's Hillsborough, UNC Hillsborough. But let me, and it's not Maine. I'm sure I'll get fired for pointing that out, but it isn't. Anyways, the answer to that question is about 400. We saw 4 million ED visits in 2022 at geriatric emergency departments around the country. And the momentum for the rate of adoption is increasing. The long-term goal is not that everybody becomes an accredited geriatric ED. There's a whole program. One thing I learned in 2018 is hospitals love stickers. So if you create standards and you hold them to them, and then you give them a sticker, if they accomplish it, that they can put up on a billboard, that's a winning strategy. But the long-term goal is not that every hospital has a sticker, but rather that the standard of care evolves so that it isn't surprising that we would do the right thing for older adults, but rather the system would be designed to make that possible.
And you you mentioned before we even got on with everyone else about some of the COVID trying to the COVID challenges. I mean, you were moving along, you were creating the need for and the business case and the care case for geriatric emergency departments. And then in just a few minutes left, then COVID came. I'm wondering how that either derailed or helped to make the case, because COVID affected our older population so much, and the need for sort of additional spaces. Wondering if that actually helped to make the argument you were trying to make all along.
Absolutely. You know, when COVID first came, we were all like, uh-oh, time to shut her up. And then we had there's all kinds of organizations here. I'll put one more in there. There's the Accreditation and there's the Learning Collaborative and there's tons of stuff. But we had our next webinar for the Learning Collaborative, and we had our largest turnout ever. It's really just aimed towards clinicians around the globe. And we were like, we can't stop. Like I mean, if ever there was a situation that made it infinitely clear that redesign of emergency care for older adults was needed, it was COVID. Not just because of COVID, but because the experience of going to the ER or dropping your loved one off at the ER, wondering whether they'd ever see them again. Did a campaign with AARP, you can Google Caregivers Are Not Visitors. I think that's a very important campaign to help hospitals think differently about infectious disease spread between visitors and caregivers. But anyways, that one's got some traction, but also the number of excess deaths that were not related to COVID. So people were staying at home and dying at home or having strokes at home because they were scared to go to the ER. So if there was ever a situation, and again, I just want to be really clear, I am so proud of our nurses and doctors and others who work in the ER. Like, it's tough and they're doing the best they can. And the vast majority of them are going above and beyond. But if ever there was a situation that showed that the system of bringing all the sick people together and hoping that disease doesn't spread perhaps wasn't optimal, it was COVID. And so we actually accelerated rate of adoption. I think we've seen CMS accelerate conversations around adopting some of these programs. And as we work through the finances, it's leading to an acceleration in the financial background, the sort of the value-based care and risk-based contracting that makes it possible as well.
I'm having to censor myself so much because I know we're running out of time and there are things I want to say and ask, but I will hold off. We have just time for one more question. So what I'm going to do is I'm going to make it a longer question. I'm going to combine my question with Sue Deaton's question, except for Harold might be typing one too. So maybe we'll get two in, which is there's so much going on. We as the coalition, the North Carolina Serious Illness Coalition, we want to help to amplify your work. I'd say promote your work, but I was reading AARP's magazine the other day, and I was reading about Geriatric Emergency Collaborative. So clearly, and you've got great ways. But how can we engage the coalition? Sue Deaton asked about how do we engage community organizations? Basically, how can we help you help us? So what can we all do to work together to help advance? Because you're doing such important work that impacts all of us. I know it's impacted me personally so much as a visitor, as a not visitor, but visitor to the emergency department. And I'm seeing some of my friends nod who I know have spent way too much time recently in the ER.
I think at the end of the day, this needs to be a social movement. It's not really a healthcare movement. It's about society saying, hey, here's what we demand. Here's what we expect. And it's not that you get them accredited in our program. That's not necessarily what you do, but like we expect an evolution in care standards for our frail or older folks. And so both the governor of New York and the governor of California have put geriatric EDs into part of their response to celebrate the aging of America. This is not a silver tsunami. This is not a natural disaster. This is what winning looks like. We celebrate our older adults and we celebrate the aging of our world because that's fantastic. But we also have to plan for it. And both the governor of California and the governor of New York have specifically put this into their plans for how we're going to address this. San Diego County made every emergency department in the county a geriatric ED. They led it at a county-wide basis. So my answer to that question is twofold. One is with your local hospitals, just write them, send them a letter, stop by and say, you know, hey, George or Sally, whoever you are, why the heck aren't we doing this? Explain to me why we're not doing this, right? Because I think your voice carries more than mine in many ways. And if we're involved with state government at all, New York did it. California did it. Now, I guess there's always politics to play. We'll try and get like Oklahoma to do it too. And then we'll have but we can navigate this. We can navigate this, and we should be doing it at a hospital, county, and state level. And the voice of our population saying, no, this is what we expect is, I think, the most important thing that you can offer up. We can make it better, and we can do it in a way that's by far most importantly, better for our patients and their loved ones, but also in a way that wastes less money at the same time. We absolutely can. We've published in JAMA Open that for each patient seen at a high level geriatric ED, we save Medicare $3,000 on average over the next 60 days. We can absolutely take better care and do it in a more sustainable way. And it shouldn't be hospital by hospital. It should be the community saying, this is what we need to do.
Dr. Kevin Biese, cannot thank you enough. I think that's a beautiful way to end, even though I know none of us want to end because there's so much we want to talk about. But I think ending on the collective power of us as a social movement to make sure that we're all getting and our loved ones are getting the support they need, both in the hospital and outside of the hospital, I think is a beautiful way to end. We cannot thank you enough. Please stay close. We will all continue to stalk you and bring you back into the coalition. But there's so much happening with your work and your voice, and we want to make sure you always have a platform to help share your efforts with us. So thank you.
Thank you all very much. Thank you for everything your team is doing. I look forward to working together in whatever way we can. Thank you.